Good afternoon. Welcome to the Medical Center Hour. I'm M.H.A. Childress from the Center for Biomedical Ethics and Humanities, which brings you these weekly programs. Today's program title, Healthcare 2020, Your Practice, a Disruptive Prognosis, sounds like a direct address to the practicing and soon-to-be practicing health professionals in our audience. It sounds like something of a challenge even. But really, our title is intended for everyone here, doctors, nurses, other clinicians, students and trainees, patients and prospective patients. We're all on notice. Changes loom for healthcare service delivery in the United States within the next decade, nationally and locally, for practitioners and patients alike. Pundits of all political persuasions agree that we will soon see profound, fast-paced transformations in the ways that doctors and nurses and other health professionals work and in the places where they work. The 2010 Affordable Health Care Act will be but a small part of how healthcare by 2020 will almost certainly be somewhat differently organized, differently practiced, differently overseen and regulated, even differently financed. How should we be getting ready for what promises to be a tectonic shift in practice conditions? We're pleased to welcome to the Medical Center Hour today two thought leaders in healthcare, seasoned expert Gary Filerman, president of Atlas Health Foundation in Washington, D.C. He's also the former chair of Georgetown University's Department of Health Services Administration. We also have R. Edward Howell, Vice President and CEO of the UVA Health System. You'll find brief biographical sketches of both gentlemen in your handout. Together for us in what may be an eye-opening and even perhaps discomforting presentation, Dr. Filerman and Mr. Howell will describe the new clinical practice environment they see fast approaching, and they'll question clinicians and healthcare organizations' preparation for it. Once they've offered their views, we'll be very eager to hear from you, your observations, your comments, your questions, and there will be some discussion time at the close of the hour, so we'll welcome your comments. And now please join me in welcoming Dr. Gary Filerman and Mr. Ed Howell.
Well, I'm not sure I need this on if I'm using this.
It'll be fine. One minute or two.
Okay?
Yep.
Well, Marcia, in a way, gave a very effective summary of the perspective that I bring to this podium. I want to call your attention to the first reference on the handout. That's this new wave of innovation, how the healthcare system is reforming, a Commonwealth Fund publication that just came out, as particularly effective in bringing you up to date, summarizing a lot of the changes that are going on, and linking you to concrete examples of where the action is. And the reason that this is so effectively put together is that the fund did this for the orientation of journalists who are covering the field. And it was published, as you'll see, as a supplement to the Columbia Journalism Review. So it's out of our usual literature flow, looking in, and therefore I think you will find it particularly helpful in getting your arms around what's going on. Well, it's a great pleasure to be at this university and to share the podium with an old and highly respected friend. As Marcia said, I'm going to set the stage. I'm then going to turn to Ed, give him an opportunity to agree totally with everything that I say. And then we're going to open it up to some conversation with you. It's about health system change and an attempt to get us away from our usual sort of passive observation of a debate that's dominated by health economists, other witch doctors, and policy analysts. And it's really about you, who are healthcare practitioners, rising practitioners, would-be practitioners, and change in personal terms. As Marcia said, we are on the cusp of seismic change, and the sensation of the ground moving under our feet is an appropriate metaphor and maybe a kind of reminder of the experience we all shared a few months ago, the ground moving under our feet. But certainly it's appropriate characterization of what's happening to us today as professionals in the field. If the conversation is successful, you're going to leave here knowing that the movement is real and profound, with a somewhat better understanding, maybe the convergence of the forces that are moving, and with some informed anxiety and about your own footing, if not your own direction. Bill Gates attributes much of his personal and managerial strategic planning success to a process that he called zooming out. I don't know if you've heard him talk about that, but he talks about this process where he just disconnects from everything and wipes his desk clean, gets himself, turns off all the communication systems, including Microsoft, and allows himself to be impacted by a whole new variety of novel sources of information, and the result of that process is, for him, was innovation and often some very disruptive adaptations that he carries back into his work in the company or now in the foundation. So he usually zoomed out for a week. So we're inviting you to zoom out for an hour. But it's a very informative exercise as a process. Now, many of our colleagues avoid prognostication about the future of health services and health practice because they always say, well, there's too many things in motion, too many variables in play for us to draw any actionable conclusions. Others approach this by saying, giving you a variety, a menu of if this, then, if this, then. And they sound wise, they sound informed, but they're very safe to do that, of course. And then there's the others that we've all seen who boldly prognosticate about the future, sort of plugging in the future fad of the month. And they usually put out a popular book. They make a lot of money giving quick and dirty lectures at professional meetings. And you've all heard them. They're entertaining, but the danger is that they're taken seriously by people who are sort of looking for, uncritically for answers, and we hope to avoid those pitfalls. Ed and I think, have a high degree of evidence-based confidence in the direction of the movement. That we think that what's happening under our feet is really pretty clear. The pace of change is accelerating. So zoom out, and you will recognize that it is inevitably, and in many respects personally, disruptive and discomforting. I think of the path forward personally as whitewater. Rough, unpredictable, but interesting, challenging, and with some risk. So we're all in it together for the ride. So let's be very clear about politics and policy in this charged environment of the day. The health insurance reform law, and that's the correct title for me, the health insurance reform law, is going to have very little effect on the basic forces of change that we are all in the midst of experiencing. That's the problem with the law, in some respects. The law does help to focus a lot of attention, obviously, clarifies a lot of issues, but it doesn't make any difference what the court does, what the Congress does, how it survives, whether it's intact. The work of healthcare and health system and health practice reform will go on at an accelerated pace and many of you will be carrying that burden forward. The changes that are in march now will continue apace, and they are actually dismantling much of the structure and pattern of the system and practice as we know and you are experiencing it today. We use 2020 as a useful reference point. We think that most of the changes will be converging at that point. It's not very far away. Give us a couple years of grace. We might be off by 2 or 4 before we reach the tipping point. It's not going to be much longer than that. For sure, in 8 years, all of you in the medical environment, broadly defined, are going to be trying to keep your heads afloat. Some of you may bail out. I have no doubt that there are some people in this room that are going to find it a very uncomfortable environment, and you're going to end up selling insurance or whatever else you might want to do, because it's not what you expected, it's not what you planned for, and it's not what you are being educated for, I may dare say. You all hear the expression, we've all heard it, demography is destiny. Aging. Don't dismiss it as a somewhat distant phenomena that will have some unpredictable effect on, obviously, all of us personally, but on our practice environment. You know, in 2020, there's going to be 55 million ethnically diverse elderly in this country. And I want to underscore ethnically diverse because it has profound implications for your practice environment. 135,000 of them over 100 years of age. Every month, 10,000 people in this country pass the age of 65. What does it really mean? It means that there's going to be a lot of frail, elderly people who will be living in the community or living in some support system, and they are the patients of the future. Epidemiology is destiny, keeping the population in mind. The vast majority of the patient encounters, overwhelming majority, going to be hypertension, depressions, diabetes, arthritis, asthma, Alzheimer's, and a changed pattern of cancers and heart diseases. Not due to etiology, but due to very consequential revisions in the therapeutic processes. Due to disruptive technologies, disruptive drugs, disruptive devices, disruptive adaptations of genomic medicine and personal medicine. Problem is that that's not what you're being educated for today, because we don't know what those are going to be. We do not know what those are going to be. And in 2020, they will be adopted into practice at a much faster rate than is the case today. Forget that 17-year business that you've all heard ad nauseum. You remember, you've all heard the, I hope you've heard it, not I'll remind you of the observation that's attributed to Sir William Osler. It was supposedly to the graduating class of 1905. I looked at the 1905 lecture. It's not in there. I can't find it, but it's somewhere. Where Osler said to the graduating students that half of what you learned here will be obsolete in 5 years. And unfortunately, I can't tell you which half. That half-life is shortening. It's very serious implications for the pattern of practice and the educational system 8-10 years from now. So, in 2020, you, physicians, nurses, advanced practice nurses, therapists, pharmacists, just about everybody, you're going to be either the salaried employee of an integrated health service system, or the salaried employee of a large, probably multi-specialty group, or a partner in a large multi-specialty group that is owned or under contract with an integrated health service system. The little independent practice that will remain, and it won't be very much, will be primarily older physicians in non-hospital dependent practices and in a few uninsured services. Won't be much action outside of that decreasing realm. The consolidations that are happening every day around us are setting the stage. The freestanding independent hospital is an endangered species. Every day you pick up the literature, literally every day you pick up the literature, and there's coverage of another consolidation or merger, many of them involving hospitals, but reaching far beyond that. Group practices growing at an increasing rate, enlarging at an increasing rate. Ultimately, there's going to be fewer but much larger health system, group practices, a much expanded package of services as they employ other kinds of health providers and service providers. We're seeing them, adding them every day. The same thing is happening to the employment pattern in hospitals and in integrated healthcare systems. The number of physicians who are employed in hospitals, as you know, is skyrocketing right now. And the indications are from research among residents and others that is the preferred pattern of the future. Virginia is going to be covered by 3 to 5 healthcare systems. Won't be much action outside of that, certainly. These systems, I don't know why I talk about Virginia. I don't think they're going to respect state lines. An integrated health system owns or contracts with the full spectrum of services that respond to that epidemiologic and demographic profile that I described to you. That's the whole enchilada. That's hospitals, long-term care programs of all kinds, primary care services in the malls, hospice both in the community and in the institutional setting, and very importantly, hospitals at home. Keep your eye on the increasing emphasis as the financial pattern and organizational pattern changes, the increasing emphasis on providing hospital-type services at home. That paper I referred to at the outset, I think cites a couple of connections to some of those innovations. Now, in all of this, the systems are going to be mainly concerned about how to reduce beds. And a lot of people in places like this are going to be walking around wringing their hands what to do with those old buildings, those new buildings you're building now. Because you won't need them and you can't afford them and make great dormitories. Money flow is really the driver here. Many of these systems will partner with insurance organizations to become at risk for the care for a defined population. That's already beginning to happen. They're emerging essentially as accountable care organizations. The reason why the owners of all these widespread variety of healthcare provision organizations are willing to sell out is because the money is going to be controlled by the integrated delivery system. And the money will follow the patient. You know that Medicare is experimenting with bundled payment. Other payers will follow. Bundled payment. We're going to pay you one fixed amount. You thought DRGs were complicated. We're going to pay you one fixed sum of money for all of the care provided in an episode, no matter where it takes place. Doctors, hospitals, long-term care, it's all going to come out of that one check. So the integrated healthcare system is under great pressure to press the service to the point of lowest cost. Keep people out of the hospital, close those beds, and redefine the workforce mix accordingly. Under those conditions, these other organizations have very little economic future unless they can contract their way into the system. Don't let all of the issues that are being raised now in the context of innovation and bundled payments, the complexities of 2012, distract you from the realities of 2020. These are short-term, resolvable issues to which the system, the financing system, and the delivery system are in fact adjusting every day. There is going to be little, if any, space left for fee-for-service. And that, my friends, removes one of the great barriers, one of the great conflicts of interest that prevents the profession from the realization of the oath, first do no harm. The implications of this structure and practice pattern for quality of care are really profound, and they're modeled in prototypes like Kaiser and in the new Cigna experimental program in Memphis. But we're talking about, in 2020, the places where we're all going to work. Now, having sketched some features of this professional and organizational geography, I want to call the attention of this audience to two challenges that are going to be addressed by the structural changes of 2020. And if I get my point across, most of you will maybe leave the room a little angry at me for bringing you face to face with this, but within the confines of the room. The first is the challenge of assessing, maintaining, and improving professional competence. The second challenge is to integrate research into practice, or better said, practice into research. These problems are interdependent, and so are the solutions. The health services research and quality of care sciences of the past decade have generated a crescendo of evidence of the failure of CME, CNE, CHE, whatever you want to call it. And I know in these hallowed halls, we pay great respect to the CNE enterprise and all the work that's gone into, particularly in the last 5 to 7 years, to trying to improve its effectiveness, its theoretical, its practical, its delivery base. But as much as we manage the message and we labor to improve the system, to make it acceptable and digestible. The fact is, if you go 100 miles out of town, they're not engaged. Nursing's not engaged at all, really, except to the extent that there's some remnants of the in-service education model, most of which has been reduced in order to save a few dollars. What there is out there is an effort to do the minimum necessary to maintain a license or a board certification or to qualify for medical staff membership. That's not engagement. Not many people are doing something differently as a result of the engagement. The evidence that I'm talking about undermines the public mythology that we've maintained professionally quite well of continuing competency. It explains a lot of the slow dissemination of research or evidence-based innovation and trial-based innovation, and it explains a lot of poor quality of care. Now, Health System 2020 embeds most of you in a healthcare structure that has a very direct stake in your behavior. It has a very direct stake in your demonstrated outcome-based results. That's a huge change in environment. If money's the driver, EHR is the glue. Integrated health systems are organizations in which the EHR generates the data for monitoring the health of the population and the behavior of the providers. The data are generated at the bedside, the point where most CME actually does work, and provides a feedback circle in real time to the organization and has a stake in the provider's behavior. Much of the CME enterprise of 2012 is going to fade into well-deserved obscurity. Health systems will develop their own competence and capacity to work with their providers to help them realize the full potential of their professionalism. But it'll be within the delivery organization. Second point. In spite of all the recent attention to translation, the paths of clinical research and practice in 2012 are increasingly divergent. Much of the research agenda is not directed to the demographic and epidemiological profile of 2012, let alone 2020. Much of research focuses on questions that are not central to most patient care encounters in community practice. The problems of most patient care encounters are not the subject of research. And it's not just the clinical aspect, it's the organizational health services aspect. The clinical trial enterprise is in trouble for a lot of reasons. Prominent among them is the overdependence on academic health centers, where the patient mix and the practice mix is not at all representative of the real practice setting in which the applications of those trials and that research is supposedly applied. That is, if indeed you can recruit and retain sufficient subjects in the first place. That's a difficult situation to face, but if we're going to address the ROI, the return on investment of the research enterprise in this country in the next few years, that issue of relevance to practice has got to be addressed openly. And I think the director of M.H.A has set the stage for that. But these issues are both translational and generalizable. In contrast, the integrated community-based health system does provide the appropriate patient base and practice setting for clinical and health services research that does respond to the epidemiologic and demographic profile that I described. The system's health record, not as it is, but as it will be, provides a huge reservoir of information about the population and about the individual across all the delivery settings and over time, far beyond what can be accomplished in the episodic environment that we meet in today. Meaningful use will be redefined to include clinical research and health services research. It's not in there now. The challenge, friends, is to convince the public, medical and nursing educators, and the health systems that clinical research is an essential component of quality care wherever it is delivered, and to align the incentives accordingly. The orientation and education to do that's got to start in medical schools, medical education, and in residency programs now. So I turn to head, says the University of Virginia Red.
Thanks, Gary. It's actually an honor to share the podium with Dr. Filerman. I've admired his work for a long, long time, and I would share with you that we're fortunate to have a person who's both thoughtful and insightful, as well as you can see a little bit out on the outspoken side, to be with us here today. Yes, Gary, I think the University of Virginia health system will be ready, or at least we should be ready, in large part to the fact that we're at the final stages of completing a strategic plan that I believe has incorporated many of the trends and the concepts that you shared with us today. Although I would share that this is the first strategic plan we've had in about a decade, and a part of our future life is going to be keeping up with those tectonic changes. And so strategizing is going to be, I think, a part of our everyday life, because indeed change, I think, will be a part of our everyday life. Certainly more change than I perceive that I've had at any time in my career. And I want to remind you, I started my career when we had cost-based reimbursement. Boy, those look like the good old days. And I'd encourage all of us to do what Gary suggested, zoom out. I think the change is so rapid that we can get caught up in it and not knowing our world is changing around us and having an awareness that we need to change. You've heard the analogy of boiling a frog. I worry that as healthcare providers, we have some of that risk if we don't step back and look at what's going on around us in a broader perspective than what we have to do day to day. So I certainly agree with Gary on that. Gary talked a bit about fads. I'd share with you, healthcare is probably an industry that's more prone to fads than any other industry I know. My mother would often tell me, well, if Johnny jumps off the bridge, would you do it? Anybody hear that? Am I the only one? I think that's an admonition that we ought to hear very clearly in healthcare and not get caught up in doing it because everybody else does it, Gary, and being more thoughtful about why that makes sense for us. It's been said that all politics is local. In many regards, I think that applies to healthcare. In my career, I've been in a few places, and I would share with you that much of the culture and many of the systems supporting the delivery of care do change from one place to the other. So the idea of a silver bullet that everybody can adhere to and one size fits all, I think is not likely to apply to the responses to healthcare changes in America. Certainly I agree with your comments about the aging population. This, I think, pretty graphically depicts it here. And this shows the population 65 and older. And you can see that the impact of that aging population of over 65 is going to have a tremendous impact on us. I tried to get a slide that projected it out to 2040 or 2050 and couldn't get one. But quite frankly, I think we're concentrating on the growth up to 2030 or 2035 or 2040. But Gary, I would share with you that after 2040 and beyond, it's going to have an impact on us as well. Because for sure, I don't know if the disruptive technology is going to empty out our beds, but I think the decline of the baby boomer generation is certain to empty out our beds. And so the reason we see so many cranes on our campuses today, I believe, is in recognition that a hospital only lasts about 25 years, and in 2045 or 2050, that population is no longer going to be with us. Thanks, Mom. And that's a way of emphasizing my point. Gary talked about 133,000 centarians, over 100 years old. I read an article last week that was the results from the Centenarian Olympics. Centenarian Olympics, do you know what that means? People who are in track and field events who are 100 years and old. Yeah, and a guy set the world record for 100 meters for people 100 years and old. 34.4 seconds. And I thought, oh, geez. And then I got to thinking, what would it take me to run 100 meters? And so I think, you know, we don't usually think of people over 100 years in the context of athletic performance. But I bring it up to say it will be impactful. It'll change not only what we think, but how we act as well. Gary talked a bit about the growth of diseases, and I would share with you that our strategic planning recognized those and is having us concentrate the investment of many of our resources in many of those diseases: heart, cancer, and the neurosciences, because in fact those diseases mirror that change in the demographic profile. And I would share with you, Gary, that we recognize what you say in terms of the importance of embedding clinical research into the clinical care. That's an inherent part of our strategy, including reaching out into community settings to make sure that that research had that community base to it. Because we recognize that it doesn't all occur here in Charlottesville. When Mr. Flexner came here about 100 years ago, he worried about the absence of disease and pestilence in Charlottesville. And I'm happy to report we still have a relative absence of disease and pestilence. But that recognized that we're going to have to work with community providers in ways that we've never worked with before. Do I agree with you in terms of disruptive technology? Yes. I think, though, that as a good example, a decade ago we had no robotic surgery here at UVA. I just got the statistics last year. We did 340 robotic cases. We generally think of 250 surgical days, so that means we do more than one robotic case per day now. There's some real disruptive technology, and we're on our second robot. But I believe that more disruptive technology will occur at the molecular level. Over half of medical education now is taught at the cellular and subcellular level. I think over time the greatest disruption will be molecular rather than mechanical, as I think surgery is about as mechanical as we get. We've invested heavily in the electronic medical record. I watch what happens when I mention the word epic. But in reality, I think it's a glue, but it's a tool. All too often I hear conversation around it being a solution. It isn't a solution, it's a tool that we have to use to create the solution ourselves. And in many ways, it's going to require us to practice healthcare a bit differently. I'd also share with you something that you didn't mention that causes me the greatest concern. You talk about workforce. All that demand is going to have to be met somewhere. And I'm increasingly concerned that we're not going to have the workforce to meet it. Whether it be physicians, this is, I hope I can get the pointer to work. This top line here is Susan Kirk's greatest concern right now, because that's the number of residency positions that we have in America. And if you look at the numbers here, we reach a point before 2020 where the number of U.S. graduates exceeds the number of residency slots. And we all know that the individuals in practice need to complete their residency. And while we have lots of new medical schools opening up and places like us who are expanding our medical schools, nothing is being done about this top line. And until something is, I worry greatly that even the most advanced disruptions are not going to release the demand enough to be able to deal with it. And yes, I'm concerned about it because we're in the physician education business, but we're also in the nursing education business, and we're already facing the shortage of providers here. I was at a recent meeting in which the presentation was on the Ochsner Clinic moving to a 7-to-1 patient-to-nurse ratio in their facilities. And the reaction is 7-to-1. They're doing that by using a number of supportive personnel because they anticipate in New Orleans it's already very challenging and it'll only get worse. And I use this as an example that we're going to have to be creative in making sure that we utilize the resources that we have to the highest level that we can possibly expect them. And there will be a glue, Gary. I think the electronic health record is a glue for all of us. Lastly, I would observe that you talk about an integrated health system. We probably get a high B+, maybe an A- in our integration. We've got clinics and hospitals, the physicians, the nurses, the hospital are all under one ownership. We have a long-term acute care hospital. We have a rehab hospital. We have a community hospital. We're pushing the electronic health record out into the community. We have relationships with nursing homes, but we don't have one. So I think in that continuum of the integration you talk about for the future provision of care, I think we're well positioned. We will have to change like everyone else, but I think in response to your question, yeah, I think we're ready for the future. But let's hear what the kind of questions folks have to ask. Marcia?
So I've got a mic, and if you have comments and questions, we'll take them. Please identify yourself when you make your comment or ask your question.
Thank you. This is a question for Dr. Filerman. I'm Sharon Utz from the School of Nursing, and I noted in your presentation no mention of health departments, state health departments, and what their role might be in the future that you described.
That's a really interesting and timely question because health departments tend to be overlooked. I have no doubt that the integrated health systems will create organic connections with health departments for a lot of reasons, sharing information and so on. But health departments are struggling. And one of the core issues that a lot of us don't see is the inability of health departments to attract and retain really competent professional staffing. Counties can't afford them. There's 3,200 counties in the United States. You know, we're not talking about the 40 very visible, high-flying, highfalutin health departments that are cranking out research papers. We're talking about all the counties of the state of Virginia. And they have a very, very difficult time recruiting people that are going to help them realize their potential. It's an unanswered issue. There's a new program to accredit health departments, which you may know about, in an attempt to kind of raise the understanding of the governmental authorities as to what kind of resources are necessary to make them achieve their potential. But it's a very critical issue, and I don't have a glib answer.
If I could pile on a little bit, I think when we think about the staffing for health departments, I think we have to broaden our thinking to think of government agencies generally as they support healthcare. And share with you in Virginia, the Department of Medical Assistance that administers the Medicaid program hasn't had any increase in staffing for nearly a decade. and look at the growth in the number of Medicaid enrollees. The folks in our state Medicaid office are working about as hard and as fast as anybody could work.
Hi, my name is Catherine Reynolds, and Dr. Filerman, I was wondering about your perspective on the influence of, with all the challenges that both of you have talked about, but as the baby boomers come up, they're privy to instant information. They have a higher level of general medical knowledge and health knowledge than the community in general in the past, and along with media input as to what to ask your doctor for. I was wondering how you think that's going to impact both healthcare and then this competition between healthcare systems and insurance companies with regard to customer satisfaction.
Well, can you hear me all right? One of the key factors in that picture that I'm very excited about is the access that the systems are beginning to provide directly to their clients, enabling me to go online and to read all of the notes in my case file. They're no longer the private domain of the profession or the professions. They're totally available to me and to whatever providers I may designate or family members to have access to them. And that's one new element in the equation. The second, of course, is just, as you pointed out, the level of knowledge that people have, to the point where I walked into my urologist a couple of weeks ago and he said, well, tell me what's new. And I'm sure he asks that of many patients because they do a better job of keeping up and have more time to do it than he does. So I don't have an answer for that, but it's all part of the changing environment. It's very exciting. That's that excitement that I'm talking about. And I think it really is disruptive to the expectation of a lot of practitioners, no question about it. And you know, there's still a lot of people who have a hard time turning from the patient to the computer and thinking about the template and being drawn into it. But that's generational, let's face it. And so as the people my age fade out, we're going to overcome a lot of those barriers.
Hi, my name is Carolyn Engelhardt, and I teach health policy here at the University of Virginia. I'd like to thank you both for an extremely provocative talk. This is the kind of stuff I could listen to all day long. And
well, that's bad. That's an addiction.
I know, I'm working on it. But I want to push back a little bit. For those of us old enough to have been watching sort of the gymnastics of our healthcare delivery system, I can't help but be struck with the similarities of now and what happened in the early 90s with the managed care revolution.
Yes.
We had capitation. Today we're calling it bundled fees. We had HMOs. Now we're calling them accountable care organizations. We had the Agency for Healthcare Policy and Research that was almost completely dismantled by the orthopedic surgeons because they didn't like what you did when people had lower back problems. So I would just ask you to talk a little bit about how you have controlled for powerful vested interests in your hypothesis.
Go ahead, Gary.
Well, I think we are seeing a change in the operating environment of the interest groups. They too have been very impacted by the accessibility of information, particularly in the last 4 or 5 years, so that the evidence that is extant in the land makes it more difficult for them to pursue, at least in the public arena, really self-serving or let's say preventing changes. But you know, as I say, the ground is shifting when the business community, for example, begins to, as it has in the last couple of years, begin to really divide between throwing its weight behind the Chamber of Commerce and their sort of resistance to change, and the self-interest of the large corporations and their knowledge that they can't continue to support the old way. So I think there's a lot of change taking place in those organizations. I'm struck by just in the case of my graduates from Georgetown, the number of them have been hired into those groups. We don't include them on the alumni list, of course, but you know, they're working for pharma, and they're working for Chamber of Commerce, and they're the Small Business Association and so on. And they are, and I take that as a sign that those organizations are, there's much more internal ferment in those organizations than there were 10 or 15 years ago. There's certainly ferment within the AMA. Very interesting to see what's happening in the AMA. Marginal as the AMA is, I have to say. And they struggle with why they are so marginal in many respects. Of course, most doctors don't belong. But you see that happening in a lot of these groups. So that ferment, under the conditions of the day, I think is really beginning to impact on those organizations and changing the ability to negotiate among them. It's not the same as it was then. And it won't be the same if the Republicans sweep the Congress. You can't push it back, I think. What do you think?
Couple
What do I think?
Yeah.
I think that the difference is that if we don't do something about spiraling spending in healthcare in this country, we're going to go bankrupt, and that it will become a budgetary issue as much as a healthcare issue.
Yeah. So it's a different background noise.
Two things, Carolyn, I know better than to try to one-up you. But I think two things we have to keep in mind. I went through all of that before. In my opinion, two reasons why the last one wasn't fulfilled. I didn't use the word succeed, I said fulfilled. One was that at the end of the day, there was a formula that withheld care, and I don't think there's going to be any tolerance for withholding care. But the bigger one was the reality that the healthcare cost issue subsided because of a booming economy. And I don't think any of us are looking for a booming economy. And the reality is that that aging population, I can personally attest to the fact that stuff falls apart and you want it fixed. And I think those two forces are going to make this different.
Mona Carney, General Internal Medicine. Thanks for the presentation. About 50 to 100 million people get their care through the healthcare safety net. Don't have access to care. And when we talk about accountable care organizations, that's usually talking about people who already are sort of in the insured pool, or at least the Medicaid pool. How does your hypothesis sort of take into account this 50 to 100 million people that are requiring sometimes even more care than those who are already insured?
Well, it's interesting. I've talked with the CEOs of 3 integrated health systems in the last 6 months or so. Actually working on this IOM trials project, trying to figure out what trials have to do with those organizations, how they can be integrated into them. And but I've pressed them on their strategic planning, and they're all assuming independently that they're going to be where those people bring their cards. That they're going to walk in and they're going to have their card, and that those systems are going to be the primary source of provision of services to those people. That's in their plan. They recognize it, and it's in their financial model, and in their model of primary care organizations, clinicians, the guys that are thinking ahead strategically, they've got that 2020 image. They're not assuming they're exempt, that that's a different population. That's their core population. very interesting phenomenon. It's on the table. They're talking about what are we going to do when those people show up in 2014.
One thing, though, I think it's going to be critical that the insurance exchanges not be under the Commissioner of Insurance, but be somewhere else if those populations are going to be well served.
Hi, Dr. Filerman.
Who are you?
I'm John Kaplinkel. I'm a neonatologist and intensivist, but I couldn't agree with you more and support your assessment that there are going to be consolidation of group practices and that there are going to be the small community hospitals that are dropping out. They already are. But I could push back a little bit on the idea of the hospitals being empty in a number of years. It reminds me back 10 or 15 years ago when we were told that you better not do any more building in those hospitals because they're all going to be empty and everyone's going to be taken care of out in the ambulatory care. And that sure hasn't happened. Just look around these buildings. And so, as an intensivist, I see group multidisciplinary practice taking place, highly focused on technology and the need for technology. That's not going to happen in the home. And I see something different for, at least for the tertiary care hospitals.
Well, their vocabulary has to change. These administrators. They still talk about market share, occupancy rates, and a competitive position vis-a-vis the institution down the street. Almost all of it in terms of bed size. And so, and there's a lot of incentive built into the present practice pattern, in spite of our language to the opposite, that it really does encourage a hospital-centric organizational pattern. And that's going to change, because you can't afford, in a bundled payment or controlled payment situation, to focus your dollars in the most expensive part of the organization. Now, nobody's going to, of course you're going to need a tertiary backup, but it's going to be backup. And I visited one system where they showed me a chart on the wall, a picture on the wall. And he said, you know what we're doing? See the hospital in the center? We're moving it over to the edge. The hospital is no longer going to be the center of the system. There's the center, the hospital over there. That's a tertiary, confined support system unit. Center of the system is the patient and the community-based delivery group. Huge way of shifting their thinking in their resource application. And when they recruit, they're going to recruit to that model. So that and the disruptive technologies. I was telling Ed last night, I was at one of the major companies in the world that produces technology, and they took something off the wall, and they said, we don't sell this in the United States yet. Little spring about that model. So when we do, it's going to change gastroenterology and surgery in the United States radically. It's going to be a huge change. It's going to be like the stent upsetting invasive cardiology. It's going to be as big or bigger. Just a little spring. Those things are all over the place. So that's going to affect, it's going to kick a lot of stuff out of hospitals.
But John, to your point, I think Gary's right. It's going to kick a lot out of hospitals. But I would speculate the last bed to close is the intensive care bed.
So on that, we'll end our hour. We hope we've left you with lots of things to think about. We hope you're not too mad at Dr. Filerman. We ask you to think about these questions and come back to us in a month, on the 7th of March. We have Dr. Molly Cook, who headed the Carnegie Commission on the 100th anniversary of the Flexner Report, the Carnegie Commission on Reform of Medical Education, which will look at the physician preparation for 2020, or as Molly is going to address, 2030. We ask you please join us next week, the 15th of February. We have a program called Message in a Bottle, Fetal Alcohol Syndrome, with Janet Golden from Rutgers University in Camden, New Jersey. Please join me in thanking Ed Howell and Gary Filerman for